So without further ado, I'm absolutely delighted to introduce our first speaker, Professor Emil Bakker, who is the current AATS president and recently appointed chair of surgery at Columbia University in New York. And he's going to talk to us about the Ross procedure in young adults. Thank you very much.
Thank you, Debbie. Thank you very much. Good morning, everyone. It's a pleasure to be here. Thank you for having me. I'm going to be giving you a little bit of an overview on the management of aortic valve disease in young adults. I understand, I think most surgeons here are adult aortic surgeons, but I'm sure you deal sometimes with younger adults or teenagers, and so those are sort of the considerations we go through when we see these patients. So, when you're dealing with a older child, young adult, there are different considerations that you take into account versus somebody who's, let's say, 65 years old. So the indication matters, of course, especially in terms of what you're going to do. Age, of course, the younger the patient, the more growth potential, the different your thinking is going to be. The appetite for reoperations, anatomic criteria matter. The size of the aortic annulus, is it a bicuspid, a tricuspid valve? And then, importantly, also the surgical tools and techniques that you have at your disposal. Not everybody is a good Ross surgeon. Doesn't mean that you're a bad surgeon. It's just simply that may not be the operation that you might want to do, and there are other options for that. So, when we're looking at a patient, we have several options. We can repair the aortic valve. We can do Ross procedure, of course, mechanical AVR, tissue AVR, Ozaki, and then the new kid on the block, so to speak. Allogeneic heart valve transplantation, which I will be talking to you about. This may be completely new for some of you. Others may know about this, but this is basically a heart valve transplant. In the same manner as you would do a heart transplant, you transplant a valve acutely from one patient to another. And so when we're thinking about these patients, we're thinking about how many, especially in the younger patients, the number of reoperations are going to endure over a lifetime. This is sort of the lifetime management of the aortic valve, the quality of life, long-term survival, and then I think something that's not being talked about much is the LV milieu, meaning under what condition is this LV working. I know I'm speaking to a room full of surgeons, so I don't have to convince you guys, but when I'm speaking to cardiologists, they will sit on some patients with sort of moderate disease for years on end because they don't want to subject the patient to a second or third or fourth operation, which that may be right, but at some point you have to pull the trigger because this left ventricle is not working under normal conditions and you may want to do something. So moving on to aortic valve repair, there's great disease variability. It's very difficult to report in a standardized way. It's very much operator dependent here. I think it's more art than science often, even though science has become a bigger part of it with measurements and so forth. And the true long-term results don't really exist. Now, of course, there are certain situations where simple aortic valve repairs are done with excellent results. I mean, aortic valve stenosis, we don't really see a lot of those anymore in children because they undergo balloon valvotomy, but nevertheless, every once in a while you get to do them, and those typically work very well. If you're doing commissuroplasty and roughing up the commissures and tightening up the central area of the cusp, those are also areas that work fine. A little bit more complicated if you're dealing with a cusp prolapse with central plication. Again, that typically works just fine. And now you get into the more complicated aortic valve repairs, such as a tricuspidization of aortic valve that was sort of really given way to a bicuspidization, which I'll talk to you about in a second. But here, the important thing is that now we're using a patch. And I think the difference between simple and complex repair, at least in our definition, is the use of a patch. Because once you start introducing a patch, and that I understand is more of a congenital sort of armamentarium piece, then you're in a different situation. And then bicuspidization of the aortic valve, which is something that really works well for the right reasons. But here again, you're using pericardium. We don't have 10-year outcomes really, 10 or 15 years outcomes, but at least in the midterm, this is the best technique. If you're going to be using a patch, a bicuspidization is really what works best. But again, here's a drawing of when we used to do cusp extensions, when we don't really do them anymore, but those were three patches for the tri-leaflet valves. And so what kind of results can we expect? Well, certainly when we're dealing with mixed disease AI combined with AS, the results are not as good as if you're dealing with just pure AS or AI. If you're comparing replacement versus complex repair, there's good evidence to show that replacement is actually probably better than a complex valve, aortic valve repair. In Australia, they've compared repairs versus Rosses. You can see the results here. The Ross has a better freedom from valve reoperation than repairs. And specifically, they compared an acceptable repair versus a Ross, which is somewhat similar, although the Ross is still better. And then if you have a suboptimal repair, definitely not as good, for sure not good. And so a suboptimal repair simply should not be done at this point. And at that, you should probably switch back to doing a Ross if that's your result. So for the aortic valve repair, for simple repairs, I think it's fine. You can do them. Complex repairs, I really would think very hard. I mean, we do bicuspidizations. But if we start thinking we need a patch for a good aortic valve repair, now sort of in our calculation, we start thinking maybe a Ross is the better option. Now, mechanical prosthesis for young adults, I don't know how often would ever use a 15 millimeter. That's the smallest prosthesis. We might use it in a very specific circumstances, but very, very rarely. The thing is, a lot of people seem to think that you put in a mechanical valve and you're done, and you can promise the patient never have to have surgery again. That's not true based on the literature. I mean, we all know problems. If you practice cardiac surgery long enough, you're going to see a number of mechanical aortic valve patients come back for some kind of a replacement, either from pannus formation, endocarditis, or patient prosthesis mismatch. And then if you compare mechanical AVR with a case-matched population, there's definitely an attrition in patients who have a mechanical AVR compared to the normal population. So that is also something to keep in mind. In children, for sure, it's very clear. So, I mean, I think in my practice, or at Columbia, let's say we do about 1,000 cases, congenital cases a year, and we maybe might put in one a year of a mechanical aortic valve. So it's very rare. And then prosthesis size obviously matters a lot. This is data from Boston Children's. If you go below 19 for whatever reason, you can look at the attrition curve in red. It's really not good. And so it's probably something that only under very specific circumstances should be done and not really otherwise. Tissue prosthesis in young adults is, again, a problem with early failures and calcifications. Again, I think this is a problem that most people will know about. The younger you are, the quicker the prosthesis is going to degenerate, so that is a problem. Again, here comparing tissue AVR versus the case match normal population without valve disease. Again, there's a good amount of attrition in the valve replacement population. Again, something to think about. So now we get to the Ross and the Ross advantage. The Ross, is the only AVR that gives you this kind of a result. This is a patient 18 years after a Ross. You can see there's no AI, coronaries fill well. The root is about the normal size that you would expect. I mean, it's just a beautiful, beautiful outcome, and there's just no other operation, as far as I know, not even the best aortic valve repair that can give you this kind of a result. This was done at an age of 6 months, and the patient is now 18 years old. And the real advantage of the Ross, besides sort of the beauty of the end result of it, is that it gives you a long-term survival equal to the general population. This is Ismail El-Hamamsi's famous paper published in The Lancet when he was working with Magdi Yacoub, and it just simply gives you the same outcomes. And this is data that has been reproduced over and over and over again in German population, Australian population, France, Canada, and most recently in the US, comparing. This is data comparing New York State and California patients who have received either Ross, mechanical AVR, tissue AVR compared to the general population, you can see the Ross is the only thing that is comparable to the general population. Bioprosthetic and mechanical AVR are in red and blue, and the risk of mortality goes up every year when you have these prostheses. So definitely Ross is favorable here. You can, again, this is from the UK, Ross versus mechanical. And then really something that's very important, what about quality of life? What about ability to exercise, do sports? And again, for the Ross, the LV milieu is what I was talking about. Your AV, your oxygen consumption is just simply keeps up and stays high as opposed to where or the other operations where it does not. I put this slide up. I don't expect you to read it. Just to say a word of caution, let's say the Ross is a highly technical procedure. So certainly it's easier to put in a mechanical prosthesis or tissue prosthesis and be done with it. And there are many, many technical steps to the Ross procedure. Therefore, by definition, many technical steps means a lot of possibilities for problems and complications. So it's not to say that it's a complication-free. I have a whole other talk on just complications. I probably have endured every single possible complication with the Ross procedure, but it's still a worthwhile operation. You have to do it well, but if you do it well, then it's definitely worth doing. And then, well, what about the Ozaki procedure? It sort of created some hype. I don't know how popular it is in Britain or in Ireland, but certainly in the US and certainly in the congenital sphere, it was at one point something that we were really interested in, and we did. I believe everybody would know what the Ozaki procedure is here and how it's done. And Professor Ozaki himself, his initial results were very good when they were published. But the youngest patient was 13 years old, so it was very much skewed towards an older population, which is not what we're talking about here. And so the largest experience with the Ozaki procedure in the congenital sphere comes from Boston Children's, Chris Baird, 51 patients. I think there may be now 70 plus patients, which really, it was sort of a mixed outcome. And basically at 1 year, 6%, 1 year only, 6% required surgical reintervention, and 20% had more than moderate AR or AS. So you have to ask yourself, well, wait a second, what's going on here? That's not a great, those are not great numbers. And unfortunately, it wasn't a sort of a learning curve type of thing. It was a real issue. We have about, more than 16, but that's when we looked them up, 16 patients who had longitudinal follow-up, 12 with autologous pericardium, 4 with bovine. So if you do Ozaki with non-autologous pericardium, forget it. It's not going to work. It's going to that patient. You're giving that patient maybe a year or 2 or 3. That's it, and then they're going to have to come back for a re-op. So it's, in my opinion, just simply contraindicated. So you have to use autologous pericardium, which really makes it so that it has to be a virgin chest. Of course, you could argue in a redo you could find pericardium, but probably not as good. In any case, so you can see already it's starting, the indications start to shrink, and not really a lot of patients can get it. And as I said, our experience has been really bad when we use bovine pericardium. All of them have required reoperations. When you use native pericardium, it's okay. We recently have had to reoperate on a patient, and so it's probably not going to be something that's useful in the very long term, but in some areas, and for example, underdeveloped countries, this is from Malaysia, it's good because homographs and other conduits don't really exist. So for the Ross, it's a little bit more complicated. Prostheses are expensive. So if you can do that and give the patient, a number of years in a rheumatic aortic valve setting, it's actually not a bad thing at all. So we would just use it in autologous pericardium. Maybe in rheumatic heart disease, in specific situations, it is good. But again, patch in the bloodstream in the aortic position is a problem. And so it gets me to the last topic, which is allogeneic heart valve transplantation, whereby basically, again, instead of doing a heart transplant, you just take the aortic root and transplant either the aortic root or the pulmonary root, depending on the needs. Now we know cryopreserved homographs of the sort that we use on a daily basis will definitely fail at some point. The smaller they are, the younger the patient, the quicker they will fail. So we know that is a problem. And so this was sort of rejuvenated initial experiences being with Dr. Ross in the 60s and others, whereby you acutely, in a fresh setting, transplant a valve. This is particularly helpful in truncus arteriosus patients, since you cannot do a Ross, since they don't have a pulmonary valve to do a Ross with. And so you can procure an aortic valve and a pulmonary valve and transplant them, again, acutely in patients who, for example, the heart donation has been rejected for muscular problem, function problem. You can take the aortic valve, pulmonary valve, transplant them, implant them into these patients, and then put them on immunosuppression. So it's really a whole different mindset than doing other kind of valve surgery, because now you're in a transplant realm, essentially. And it works really well in a domino setting. So we have a lot of patients waiting for a heart in our unit in the ICUs, but very often the aortic valve or the pulmonary valve are working just fine. They're waiting for cardiomyopathy or other problems. And so these patients, when they get a heart, when we get a heart for them, we can explant the heart, take the valves, have another OR ready, and put the patient who needs a valve into that OR and go and do the valve transplant in a domino fashion. So it works quite well. Again, you have to immunosuppress. So this is the domino heart valve. The first one was done in May 2023 at Columbia, and we've done a number of them. So our experience with this is that we've done 10 patients with valve transplants, 15 valves were transplanted, 8 with the domino system that I just explained. In young adults, it's a different story. The valve transplant, you can imagine if you're doing that in a 2-year-old with so much growth potential, and if it's proven that these valves grow, and so far on the left side, from those 10 patients, it does look like they're growing with the somatic growth of the patient. So it's really something new and exciting and different. So in young adults, the growth potential is not needed, but and immunosuppression obviously is a problem. Now, we start with 3 with the triple immunosuppression, but we end up with just tacro at the end, so it's not a really very sort of bad drug to take. You have small size availability in that setting, but that's often not needed. You have other options. And we have excellent results with the Ross, especially if you can put an adult-sized RV2PA conduit. So the role of allogeneic heart valve transplant in young adults is really not sure. If a 15-year-old came to me, I'm not sure I would propose that to that patient, but something to keep an eye on, and potentially it might work. So in summary, aortic valve surgery in young adults, well, for complex aortic valve repairs, I don't think is as competitive as a well-executed Ross. You do have a role for prosthetic valves, for Ozakis, but really those are specific indications. Ross remains the mainstay. Thank you very much for your attention.
Thank you. Thank you very much for this great talk. It's Ayman Kinawi. I'm a surgeon from Liverpool. Just want to know your take on young adults with a history of rheumatic valve disease, but currently there's no activity and the pulmonary valve looks okay on images. Would you consider a Ross, or you would have concern on that? Thanks.
I would, if the disease is burnt out, that's, I think, is the key. If it's a recent flare-up of rheumatic heart disease, I would not do a Ross, and you need to do something, I would not do a Ross. But if it's in the past, years in the past, I would consider a Ross, yes, I would. Even though I understand it's a relative, you could argue about it, but the problem is, what else do you have, right? I mean, what are the other options available? That's the issue.
Charaj from Bristol. I'm an aortic surgeon. I'm really interested in your allogeneic transplantation and the dominoes story. It, of course, works in big transplantation programs, which there are many of around the country. In the UK, practically speaking, transplantation is centralized, and there are lots of cardiac surgical centers outside that, right? Can you see a way in which it can practically work, where you do the first transplant in one hospital and then the aortic route? How much time have we got? Have we got any data on that?
Yeah, no, that's a great question. In fact, that's what's being done. I mean, most of the valve transplants probably are going to be done in that manner, just like heart transplantation. So you go, and so we have done this in a handful of cases. You get a call for a heart that was rejected but has good valves, and you have a patient waiting. So you go and you actually procure the heart, the entire heart, and you the same way as you would for a transplant. You know, with you give cardioplegia. I know, you know, you could say, well, why are you even giving cardioplegia? But we don't really know what we're dealing with here, so we're doing the same thing. So we give cardioplegia, we procure the heart, we put it in the same, you know, ice bucket, etc., whatever technique you use, and then bring them back to our institution and then do a transplant. So it's using, again, the same way. We might not be as, you know, we might not do it at 4 in the morning, and we might do it at 8 in the morning because, again, we're just taking the valve and we put, in the meantime, it's sitting in ice, but that's what we've done.
Branko Mimic, congenital cardiac surgeon from Great Ormond. Great talk. I have one question, actually two. The first one is in young adults with a good sized pulmonary valve. Do you do classic Ross, or you starting thinking about protected Ross and putting the autograft in some kind of graft?
Mm-hmm. So we use whether it's AS or AI leads us in two different directions: reinforced versus non-reinforced. That's number one. Number two, the size of the discrepancy of annular size, aortic annulus versus pulmonary annulus. So if the pulmonary annulus is bigger or equal to the aortic annulus, we will not reinforce. So for AS patients, typically that's the case, and then we would just simply, we might put a distal graft to keep the commissures, you know, tight. But if it's an AI patient, with a dilated annulus, in that case, yeah, we're doing the sort of what we call the full jacket Ross, which is we put it into a Dacron graft and implant it.
And the second question is about considering not such a great experience with complex aortic valve repair, where we use different patch materials, and also not great experience with Ozaki. If you have a young adult patient, for example, 20-year-old, who doesn't want mechanical valve, and also it's not a candidate for us for different reasons, would you do repair, Ozaki, or you would just put a tissue valve?
Great question. So I think at this point, a 20-year-old who doesn't want a Ross, who doesn't want a mechanical valve, if it's a virgin chest and there's pericardium, I would probably go for an Ozaki at this point in a 20-year-old. Maybe not in a 10-year-old, but in a 20-year-old I would. So that's number one. If you can't do an Ozaki, well then you put in a largest possible tissue valve, and then you know, TAVR, you know, etc. So.
Thank you very much.
Thank you.
Professor Pasha.